A croeso cynnes iawn I bob un ohonoch chi sydd yma yn yr ystafell i'r cyfarfod yma, sef cyfarfod bwrdd iechyd a ddysgu Powys. A croeso hefyd i'r rhai sydd yn gwylio ar-lein y cyfarfod yma, sydd yn ôl ein harfer yn cael ei thrydio yn fyw ar ein gwefan. Ac eto yn ôl ein harfer, mi fydd 'na recordiad o'r cyfarfod heddiw ar gael i'w gwylio o'n wefan yn dilyn y digwyddiad heddiw. It's a great pleasure to be able to welcome each and every one of you to this meeting of the board of Powys Teaching Health Board. As you can see, we are meeting face-to-face in our boardroom today, having been out yesterday as a board, visiting teams and services and sites across our health board, speaking with patients and staff and gaining very important feedback. And so really, really good to be together today face to face. And as always, a very warm welcome to those who will be watching the live stream of this meeting online. And as always, there will be a recording of the meeting to watch from our website after today. So it's really good to see you. A very warm welcome. Carl Cooper ydy yn enw I, a fi ydy cadeirydd y bwrdd, ac fe welwch chi yn y man ar y sgrin enwau fy nghydweithwyr bwrdd. Bwrdd undebol ydyn ni, sydd yn cynnwys aelodau annibynnol ynghyd ag aelodau gweithredol. A chyda'n gilydd, dyn ni yn ffurfio corff llywodraethol Bwrdd Iechyd a Ddysgu Powys. My name's Carl Cooper. I'm the chair of the board. In a moment on the screen, you'll see names of board colleagues. And as a board, we're a unified board, and we consist of independent members and executive members. And also on the screen, you will see names of additional attendees that will contribute to our meeting, as well as colleagues that for various reasons can't be with us today and whose apologies for absence we have accepted. Felly, fel wedais I gynnau, nid I corff llywodraethol sefydliad, ac ein pwrpas ni, mae yna fel 4 elfen, prif elfennau o'n pwrpas ni fel bwrdd. Yn gyntaf, dyn ni yma I bennu cyfeiriad strategol ar gyfer y sefydliad. Yn ail, dyn ni yma I bennu archwaith risg wrth I ni gyflawni yr amcanion strategol hynny. Yn drydydd, dyn ni yma I fonitro cyflawniad y cynlluniau dyn ni yn ei cytuno a dyn ni yn ei rhoi mewn lle. Ac yn bedwerydd, ac yn sicr nid yn lleia, dyn ni yma I osod ac I fodelu diwylliant a ffôn y sefydliad. Our purpose as the governing body of the organisation is fourfold. And we're here to set the strategic direction for the health board. We're here to set the risk appetite in the delivery of those strategic aims. We're also here to monitor delivery and performance against those strategic aims. And very importantly, and certainly not least, we're here to shape the tone and culture in our organisation and to model that as a board. And so we also, just to explain as well, that as a board, we are meeting in public. But it's important to describe or explain the distinction between meeting in public and this not being a public meeting. And so we don't invite direct contributions from members of the public. However, we do invite members of the public to submit questions or to offer feedback. And if anyone would like to ask a question of us as a board, please look at our website, and information is available on our website as to how to submit those questions. Just before we come to the substance of our business today, just to explain that when we come to item 5 on our agenda, and that the papers that we will be considering during our meeting today are all accessible and all viewable from our website. But item 5 is the so-called consent agenda, and there are a list of items under item 5 that we consider to be not contentious, not controversial, and therefore don't need discussion. Nonetheless, they do need decision or support of the recommendations. And when we come to item 5, we will take those items en bloc without discussion. There is always the opportunity for any board member to ask that any item as part that forms part of the consent agenda be moved from item 5 and be placed as a substantive item on the agenda for discussion. And I will ask members whether they would like to do that in a second or two. Yn ystod y cyfarfod y bore yma, mi fyddwn ni yn cymryd egwyliau ac mi na i esbonio pan byddwn ni yn gwneud hynny, ac wrth gwrs mi fyddwn ni yn cymryd hefyd egwyl cinio. Felly, dyn ni eisiau rwan symud at yr agenda fel wedais i a welir ar ein gwefan ynghyd â'r papurau. Felly, dwi eisiau symud rwan at item 1.2. Can we move then to item 1.2 of our agenda and to declarations of interest? It's a great pleasure, as always, to have Nina Davis with us, an associate member of our board, who is also the Director of Social Services within the local authority. When we come to discuss our 2025-2026 plan, we acknowledge that there are aspects of that plan that will have implications for social services. And so after that item has been presented, Nina, I will turn to you and give you an opportunity for you to ask questions, share information, make comments that you think it will be important for us to be aware of in that discussion, and then you won't take part in the discussion or the recommendations, acknowledging the position you have. And so that's how we will manage that particular aspect of our meeting today. But are there any other declarations of interest from anyone in respect of any item on the agenda that isn't recorded on our register of interests? No? Thank you. So we turn to item 1.3 and the board action log. I'm going to ask our Director of Corporate Governance, Helen, just to take us through this and to draw our attention to anything that needs discussion or decision today.
Morning, everybody. Thank you very much, Carl. So there are 4 actions on the board action log. 3 of those are in relation to the anti-racism plan, which we discussed as a board back at our meeting in January. And as agreed with that board, those actions have been transferred to the Workforce and Culture Committee and will be reported back to the board at the appropriate time through the Chair's assurance report. There's one action then at the top of the log. This was due for a report also included back into our board meeting today. This is in relation to the People's Experience Framework. We are discussing that closely within our Patient Experience Quality and Safety Committee. We are also working nationally within some timeframes and awaiting some information for national release. So that will continue to be discussed in PECS and then reported back to the board. But for those reasons, it wasn't available for today. So on that basis, Carl, requesting a date change to our May board. Thank you.
Thank you. Colleagues, does anybody want to come in terms of that request, or indeed any other aspect of the action log? No, so I assume that that's supported, and then we'll move on. Fel wedi i gynnau, dyn ni'n gwahodd yn pob cyfarfod cwestiynau wrth y cyhoedd Eitem 1.4 ar ein agenda ydy hynny. Dyn ni ddim wedi derbyn ar gyfer y cyfarfod yma cwestiynau, felly does na ddim byd mewn gwirionedd I ymateb iddo fo yn y cyfarfod heddiw. We haven't received any questions from members of the public for consideration or for response at this meeting, and so there's nothing to discuss or deal with under item 1.4 of our agenda. We turn to item 1.5 and the update reports from myself, Kirsty, and our Chief Executive, Hayley. I will take my report as read, and so I don't have any additional comments to make, but I'm very happy to receive any comments or questions. Robert.
Robert, as independent member. Chair, your report notes that we take seriously Welsh Government's consistent requirement that we approve a plan that meets our financial statutory duty, and I agree, we do take that very seriously. Now, I'm aware that there have been a number of meetings between yourselves and the Chief Executive with representatives of Welsh Government or with that executive. I don't wish to anticipate later detailed discussions of how this financial duty, or more precisely the savings target, may be achieved. But is it your view as chair that Welsh Government, through its executive, understand and accept that the way we achieve that target may well have very considerable impact on the services that we will be able to deliver in the future?
Thank you, Robert. I will respond, and I'll also invite the Chief Executive to respond, because you may have some additional comments as well. Really, my response is to reinforce what I said in my report, Robert, that the consistent and clear communication and information that comes to me, to Hayley from Welsh Government, is that, and this is no surprise to us, that we do need to meet our statutory duties. There are a number of statutory duties placed upon us: financial, quality, safety, and others. And often that we need to take a balanced approach to how we meet those statutory duties. But certainly that is a consistent message. We've also had, within correspondence and messaging, a very clear message that at the very, very minimum, financially, we need to meet our target control. And alongside that, in response to your question, there is a recognition that that may mean taking some very difficult decisions, and that as a board, then we need to be ready and prepared to make the difficult decisions. Hayley, would you like to come in?
Yeah, thank you for the question. Two things to say. Firstly, obviously, we're in escalation, level 4 escalation as an organisation due to the financial position and the fact that we have not had an approvable plan this financial year and going into this year. We have corresponded with Welsh Government, setting out very clearly that we will not be meeting their requirements, and therefore, in particular, the issue around the expectation that as a minimum that we meet our target control has been reiterated consistently. I think also the key other point is about us making sure that we are undertaking a review of our plan to ensure that we take into account the resources available and set our strategic priorities, our commissioning and provider priorities in line with that. I think that there's been acknowledgement that there are difficult decisions for the board to consider, and that there is a balance for us to take between all of our duties, both financial, strategic risks, quality, performance, and finally, what we've got to do to deliver our statutory duties for patients, both in delivering healthcare, but also in terms of improving health well-being. So I think it is this very clear in Welsh.
Thank you. And thank you, Robert. And actually, just whilst picking up on the fact that Robert's asked a question, one of the things I should add to my report under board membership is that I'm absolutely delighted to say that Dr. Robert Lewis has been appointed for another 4-year term as a board member, and we certainly look forward, Robert, to continuing to benefit from your contribution and the pleasure of working with you. So good news. Thank you. Ian, you wanted to come in?
Covered, thanks, Chair. It's been covered, thanks.
Oh, it's been covered.
Yes,
Okay, thank you. And so if there isn't anything else, we move to the Vice Chair's report. Kirsty, do you have anything to add?
I'll take the report as read, Chair, but I just wanted to particularly highlight a visit to Ystwyth and Lys, and I was very fortunate to spend the day in Ystwyth and Lys Hospital with our catering team in the morning and our domestic team in the afternoon. And very often I do feel that these colleagues are perhaps often overlooked in the importance they play in our organisation, keeping patients safe and contributing to their well-being. So I just wanted especially to highlight the work of our catering and our domestic staff, who sometimes perhaps don't get the recognition or the attention that they deserve. But I'll take any questions.
Thank you, Kirsty. Important point. Kathy, please.
Just to say, Kirsty, I have had news from Ystwyth. They thoroughly enjoyed your day there working with them, so they appreciated the thought that went behind it.
I don't think I'll be getting a job soon in the kitchen. I wasn't very good in the kitchen.
Ronnie, please.
Thank you. Ronnie Alexander, Independent Member General. Kirsty, I do have a question about mental health, and in particular the power of discharge committees, which I think they don't meet very often, but there's always a concern about the quality of social circumstances reports. So I just wondered when at the end of that paragraph you say this matter is being pursued with colleagues jointly and with Powys County Council, are you confident that the improvements which are necessary will be achieved? And is it possible to say that those will be achieved in a reasonably timely manner?
Okay, thank you. Thank you for that. This issue has been recognised by senior staff within our own mental health services, and some mitigations have been put in place to try and drive improvement. For instance, using a consistent form for all sorts of circumstances reports to be filled in. That is taken the national framework, so it's the standard for good practice. I've been in correspondence myself with Nina at Powys County Council about this issue, and we will be monitoring in Power Discharge Committee usage of that form to make sure that it is consistently being used, and to receive feedback from the hospital managers about whether they feel that the reports are improving. Where there are specific concerns about specific reports, this isn't all reports, there's a variation in quality. Where there are concerns about specific reports, that will be picked up by the team and feedback given to that individual professional around the quality of the report and support to ensure that the report writing in the future is improved. So it's going to be on our next agenda at our Power Discharge Committee, and we will continue to monitor hospital managers' satisfaction with the new mitigating measures that have been put in place to try and drive improvement.
Thank you. That's very helpful.
Good morning. No other questions to Kirsty, so we invite Hayley to add any comments that you'd like to add, Hayley, to your Chief Executive report.
Yeah, thank you. I just wanted to draw attention, first of all, to the update around our vaccination programmes in the report. clearly board level awareness of the importance of vaccination in both protecting people, our communities, but also our workforce in terms of being able to stay in work is really important. And I think that there is some further work to be done, both locally and nationally, about how we can address behavioural change and in particular vaccine hesitancy. And I was keen to make sure that that awareness of the progress that we've made, that the ongoing steps we're taking to try and increase uptake is highlighted to the board. The second issue I wanted to pick up was that I am really delighted that we've signed up to the Charter for Families Bereaved by Public Tragedy, and that's a really important step forward for the organisation, and there's detail in the report. And also that we have had the first cut of information come through from our staff survey results, and this is a really, really important feedback tool to us as an organisation about how our frontline staff are feeling about working in Powys and opportunities for improvement. So I'm really looking forward to bringing those more detailed assessment of what steps we'll take as a result of the feedback from that survey through to Workforce and Culture Committee and to the board as it progresses in year. But other than that, I'm happy to be open to any questions. Thanks.
Thank you. So I don't know who was first, but Steve, please come in first.
Thanks. Steve Elliott, Independent Member for Finance. Thanks, Hayley. Can I just pick up on the staff survey? And it's pleasing to see that our response rate is higher than the Welsh average, but it's 30%. That still means that more than 2/3 of the staff have chosen not to respond. So I'm just wondering what the barriers really are to staff responding and what we are trying to do to improve the response rate further. Thanks.
Great, thank you. I wondered, Mark, whether you wanted to come in, because I think in particular how we're working as well with our partnership, trade union partners on this is going to be really important. Thanks.
Yeah, and we're aware of the fact that actually we're performing well on a basis, but we need to have trying to break that 30% barrier in terms of the percentage of staff completing the survey. Part of it, I think, we've been talking to colleagues from the staff side, and indeed more widely within our services. This is probably a case of survey fatigue. There was a case that the national survey last year, the results were somewhat late, and then before we were able to kind of do much activity around that, there was a new survey. So one of the things that is improved this year is the timeliness of the outcomes. So what we're anticipating is a lot more activity to demonstrate that it's worth taking the time to complete the surveys. But obviously we're working very closely with our trade union partners to keep pushing the importance and the impact we can have, because actually it's listened to going forward, but actually all through the organisation, managers are aware of performance and actually the interest in making sure we're addressing the concerns that are coming forward from our frontline staff.
Thank you.
Mick.
Thanks, Chair. Mick Janassi, Independent. Hayley, I was interested to see that we had signed up to the Charter for Families Bereaved by Public Charity, which feels, like the right thing to do. But I just wondered what the implications of that were in terms of leadership and operational kind of consequences. It feels like it's one of those things that's very easy to commit to, but actually it would be quite challenging to deliver on. But I just wondered, what are the implications and how would we address those going forward?
Thank you. Yes, to come in. Thank you.
Thank you. That's very interesting. Yeah, so I was going to say it's my pleasure really to attend the event where all the services were declaring and signing their commitment, and the Charter has to set up principles. Also for us as a household, we know that we've got to do calendar. So it's about when there are tragic tragedy events really that actually in terms of families that we treat with respect to honesty, and some of these stories which all of us are aware of from tragedies that have been quite harrowing in some instances. These sort of contingencies and duty that we will send with honesty, integrity, and putting families at the heart. So it's principles when people are in the midst of responding that we have a set of principles that we stick to the ground by in our effective.
That's what I'm asking is, our existing systems are they capable of responding in the way that the Charter Who can respond?
I think probably, well, in terms of our contingencies programs and the work that's into our plans, we'll also be testing some of our plans and really so going out to countering our work. So when we're in midst of in the response, we have to say to them, we will do our best, but we also have learned from repeated tragedy events that we quite helpful.
Yeah, I know we do regularly look at our contingency plans and responses. It might be interesting just to test that perspective. If that did happen, we were called upon to respond to the charge. Are we equipped to do that? Not asking for answer now, but I think it's something just to build into our considerations later.
Thank you, Mick. I look to Mayors, Hayley, perhaps Helen. So responding to Mick, how would we as a board then receive the assurance that we can step up to the mark in relation to the requirements of the charter, and that there is that capacity and capability there?
My suggestion is that we bring back and report on the detail of that to the relevant committee. But I think one of the key issues is about giving confidence and support and training to our staff. So I think it's about raising the profile of the principals and making sure that that's in place. So we can bring that to give you further assurances.
So which committee would be the most appropriate to deal with that?
PPH.
PPPH. Okay. Is that okay, Mick?
Yes.
Yeah. So thank you. Ronnie, please.
Thank you. Hayley, thank you for your report. As always, I find it very interesting. You will not be surprised that I will pick up the health protection issue, and particularly in relation to COVID-19 and the new 3-month vaccination period we have. And this, of course, is all part of COVID becoming treated as not necessarily a pandemic, but an endemic disease. So my question is, against our target rate of 75% last time, we achieved something like 50.1%. Now, I know this data is complicated. I understand the reasons for that. I understand some people take themselves out of the vaccination program, and much of this is not clear. But my question is, are we suffering from a progressive and persistent pattern of DNAs? Is that something which then means that our excellent vaccination staff are not usefully employed for all the time that they might be? And then the other issue that arises is, are we ever actually wasting vaccines? Because that is another issue that can arise. And if we have some vaccine left over at the end of the day or at the end of the period, are we doing something about, forgive me, this is just a graphic description, knocking it into the arms of staff or other people so that the vaccine itself is not wasted? Thank you.
Thank you for the question. And if I come in first, but I'll then ask Mez to respond around the sort of operational detail around the delivery of programme locally. Earlier this week, I attended the National Leadership Board, and there was a really strong presentation on the national position against vaccination and a concern that we're not meeting the target in Wales, and how do we take learning from elsewhere. For example, we were talking about Australia and the level of uptake that they've delivered in the country, and also Public Health Wales in terms of behavioural change support needed, and also the equity issues around vaccine uptake were really quite stark in the discussion nationally. So we have agreed that further work will be undertaken at a Wales basis to look at further actions we can take to further increase uptake. But I think I would ask Mez to come in with some assurance around how we're managing the delivery to reduce those issues that you've just raised. If that's okay.
Thank you. Yeah, an absolutely important point. We have seen a steady decline across Wales and indeed locally in terms of uptake of COVID vaccine. So overall uptake for us, the autumn programme was around the sort of for the mark. But the uptake varies also by cohort. So in care homes, uptake will be over 80%. And what we see is as you come down the age profile, uptake sort of decreases, and they particularly low in the clinically vulnerable group elements, which is a sort of concern for us. So in terms of sort of targeted work, in terms of our staff, we operate an overbooking process because we've been running the program now for a number of years. So then we'll know roughly in terms of a DNA uptake rate by cohort. So then we are able to apply that in how clinics are booked to make sure that time is sort of maximised. But equally, we have running parallel to that a process of how do you sort of make sure you have access to individuals that are informed, that it's an informed decline in terms of request, or in clinic if somebody DNA is on the day, they have also a process of constantly to whether they wish to rearrange that appointment or whether they're running late as well.
Sorry, I'm very conscious that the mics. So if we could just make sure that our voice levels are enough, so the mics pick them up. I'm just conscious of people that might be watching and listening to the meeting. Thank you.
Okay, yeah, sorry. And then what we've also done is increase our outreach clinics. So we monitor uptake by geography area and linked GP practice as well. So we've increased the outreach program to 7 sort of areas as well. And running parallel to that as well, Public Health Wales, as Hayley mentioned, will be doing some insight work with communities or groups, particularly where we know uptake is lower, to understand what that may be. We do know there's hesitancy as well as fatigue as well. And the important change in the COVID vaccine program now is now moving towards a seasonal vaccine sort of program as well. So then in terms of vaccine sort of wastage, COVID vaccine is a centrally procured vaccine, which is slightly different. So that is coordinated on an all Wales basis with the NHS exec, and sort of stocks are monitored on a daily basis, and weekly stock takes and weekly ordering as well. So actually minimal sort of waste element there, and that works very well. And just to note really that flu vaccine is also moving next into a centrally coordinated vaccine program as well there. So we'll be learning across their sort of take. I think I've answered all your questions. Please tell me if I haven't.
That's fine. Thank you very much.
Thank you. So thank you, Hayley, for your report. Thank you for the questions and conversation. We turn now to item 1.6 on our agenda. And as we always remind ourselves that as well as meeting as today in our board meeting, we have very important committees, and it's in the committees that, if you like, the detailed work of scrutiny goes on, and those committees, therefore, are a very important source of assurance to us as a board, and the chairs of those committees important guardians and conduits of that assurance to us as a board. So we will go through the committee reports one by one, and I'll invite the chairs of the committees to present the report and to draw our attention to any particular salient matters. And we turn firstly to Steve, Chair of Audit, Risk and Assurance Committee. Thank you.
Thank you, Carl. So in this meeting, we had several items this time for consideration and approval by the committee, and these included the 2025 internal audit plan and the 2025-26 internal audit plan and the 25-26 counter fraud plan. We also received a really helpful update of the audit handbook, which seeks to support colleagues throughout the organisation who are involved in internal or external audit. As a committee, we noted that handbook doesn't at the moment extend to colleagues involved with clinical audit. I think executive colleagues are going to give that some further thought. We received 3 completed internal audit reports, all with reasonable assurance ratings, which is good. But there are still a significant number of reports relating to the 24-25 financial year still to be considered by the committee. It's about 12 that we'll need to consider at our meetings in May and June. And finally, given our escalation status, it was helpful to receive a paper on financial controls throughout the organisation. And we were able to take assurance as a committee that effective financial controls are in place throughout the organisation.
Thank you very much, Steve. Colleagues, does anybody want to ask anything or comment on anything in response to this committee report? No, thank you. We turn now to the charitable funds. The charitable funds committee is a different type of committee. It's not in that sense a scrutiny subcommittee of our board. It is an arm's length charity of which the board is a sole corporate trustee. I chair the charitable funds, so the paper just bullet points the areas of discussion and decision that that were considered at the last meeting. I don't have any additional comments to make, but happy to receive questions or comments. Okay, thank you very much. In which case, we turn to the Delivery and Performance Committee. Ronnie is the chair of the so-called D&P, but wasn't able to chair the last meeting, and Robert kindly stepped in. So, Robert, would you like to present this report, please?
Actually, I've been in conversations with Ronnie, and he's going to do.
Marvellous, thank you.
Thank you. Just to say, Chair, this is a 6-page table report, which follows the common format that we use in these committees, and there is nothing that I need to draw attention to particularly. So I'm happy to take the report as read, but to be available for any questions or observations. Thank you.
Thank you, Ron. Please, Nick.
This may come some answer in the agenda, so if it does, happy to leave till then. But I noticed the committee escalated its concerns about the pace of progress in initiating the enhanced monitoring arrangement. But I just wondered, have been developments since, and what is the current position in relation to the
Yeah, thank you, Nick. So we will have a schedule of those meetings from our government, but we've also had, and I'll cover it a little bit later, a specific meeting fairly recently in the last 2 weeks around scrutiny with regard to our plan going into next financial year. But it will be important that we strengthen, continue to offer really strong reporting here to the committee and the board on the progress and discussions that take place in those level 4 escalation meetings. And we'll bring those forward as those take place.
Okay, so it has moved on.
Yeah.
Thank you.
Thank you. Anybody else want to comment? No, just a point of clarity from me. Just on page, I think 5 of the report, under Capital and Estates Compliance Report, it mentions £40 million of funding being available to Powys. I think that's available for Powys to bid into.
Yes.
I just didn't want there to be any public misunderstanding that we have been in receipt of £40 million, but I think in another report later on, I think, correct me if I'm wrong, we have got applications into that £40 million of about £3.5 million.
That's correct.
Yeah, okay, thank you. Thank you. So let's move on then to the Patient Experience, Quality and Safety Committee, so-called PECS Committee, and its chair, Kirsty.
Thank you very much, Carl. I'll take the paper as read, but just to highlight, as it was mentioned in the action log earlier, we were not able at this stage to progress really our discussions and our development of our people experience framework due to the constraints really of waiting on national work to be completed. Our work has to sit within a national context, and at this meeting it had been expected that the national work would be published. Unfortunately, it's not been. So as you will see in the alert, we continue to have some concerns about our ability to develop that comprehensive way in which we receive patient experience and deal with that. On better news, we received a report around infection prevention and control. Colleagues will be aware that this has been an area of concern and the need to improve. It's the second year of our improvement journey, and 24 actions have been completed. One was expected to be completed in February, and the remaining action to be completed within the planned timeframe. And we have high expectation at the PETS committee that at our next meeting we will receive a report that says that this work has been completed, and we will be able to de-escalate that item, which is very good news. And we're very grateful to everybody in that team that's worked really hard over the last 2 years to drive that improvement. I'd also just like to put on the record, we also received our medicines management annual report and the annual report of the accountable officer for controlled drugs. That was the last meeting where we had the benefit of Jackie Seaton, our chief pharmacist, who has subsequently retired. The committee wanted to put on record its enormous thanks to the work that Jackie has undertaken in that role, and we look forward to meeting her replacement, who has recently been recruited and will be joining us. So I just wanted to put on record for the board our grateful thanks to the contribution of our former chief pharmacist, Jackie.
Absolutely, thank you, Kirsty. Ian, please.
Thanks, Chair. Ian Thomas, Independent Member General. Just a thought really on where we are with Civica. In the process of the visits we did at Llandrynod Hospital yesterday, I noted that there were other feedback loops from patient experience, particularly manual ones. And I just wondered how we were capturing that and how that was feeding into the patient experience in relation to perhaps adding value to the Civica data.
Absolutely, I'm going to let Claire pick that up.
Yeah, thank you, Ian. Claire Butch, Executive Director of Nursing Quality, Women and Family Health. So we actually have a patient experience steering group, and we have membership on that group that I chair from all of the different various departments and sections of the organisation, and everybody is asked to provide what we call a quadrant report, and we specifically capture all of that information because we recognise that Civica is one way in which we capture that. As that continues to roll out and develop, it will probably become far more prominent in the capture patient experience. But actually, there is significant amount of really good work going on there with local teams engaging with service users, and it would do us a real disservice if we didn't capture that. So we try to collate all of that in that steering group, and then going forward we are aiming to ensure that is probably articulated in a more visible way through the integrated quality report that comes forward.
Thank you.
Can I just add?
Yes.
I just don't want colleagues to think that we're not collecting this information. There are multiple sources of information. I think what we are concerned about at the PETS committee is the systematic collation of all the various bits of information that flow from patients and how that can be reported to give appropriate levels of assurance to the board. So I just don't want people to think that we're not doing this. It's happening in lots and lots of different ways, but we do need to find a way of being systematic in how that feedback then is being used to drive improvement for services within the organisation and provide assurance.
Claire, you want to add something?
Yeah, and just finally on that, what I'd like to share with the board is that we are in the process of recruiting to a people's experience lead role. That will be a key role within the organisation, that will be a coordinator that will be able to bring all of that information together, and it's going to be fundamental to how we develop the people's experience framework.
Thank you. Ronnie.
Thank you. I was particularly struck yesterday at Llandrynod Hospital by one issue, and that was immediately outside the MIU. There is a notice board, and on that is a very good display for last year actually of the age distribution of people who have attended. the nature of the injuries that they have been treated for, but there was absolutely nothing on patient feedback. Yet, inside the actual animal itself, there's a notice board which bears testament to the wonderful work that the staff do. And I think it's just a missed opportunity not to display patient feedback in that sort of situation. But it's an observation which I intend to be helpful. Thank you.
Thank you. Presumably, Claire, you're happy to take that and look at the art of possible, as it were. So thank you. So thank you very much. We move to the Planning, Partnership and Public Health Committee, PPPH, and to Robert.
Thank you, Chair. Just 3 bullet points from me. First of all, strategic change report. We concentrated in particular on the enforced move of stroke services from Merthyr to Llantrisant, which will result in more patients a part of the south of this county going to the Grange. Transformation programme. Of relevance to later discussions today, the committee noted concerns over the capacity of the Health Board and partner organisations to deliver transformation in its general sense, against all the other pressures, of course, including temporary service changes. And lastly, screening programme. We received a most useful report on screening. While it's heartening to be the best performer in Wales in many, but not all, of the screening information, the committee renewed its commitment to receiving data in the future, where possible, which compares the performance of this board with that of similar populations, whether they be in England or indeed in Scotland, to augment the data from Wales. Thank you.
Thank you, Robert. Yes, please.
Thank you, Chair. In terms of the changes to stroke provision at Cartars, the report was about stroke provision for our population as a whole. It's to note, because this is a public meeting, those are temporary changes at present, and we remain engaged with the process in terms of developing the permanent model, clearly advocating for our population in that process.
Thank you, Claire. Can't see any other questions or comments, so thank you, Robert. And we turn now to the work of the Workforce and Culture Committee. The chair of this committee, Jennifer, is not able to be with us today, so Helen, our Director of Corporate Governance, is going to present this in her stead. Thank you, Helen.
Thank you, Carl. So you'll see from the report that this meeting of the committee happened quite close to the proximity of this board, so you will get a fuller report that will come through to the board. You can see in the report a list of the agenda items that were covered. Just 2 things to raise the board's attention really in the alert and advise areas. The alert one is in relation, it's not new news to us, but in relation to RIF funding, regional integration funding. There is currently some risk of the availability of that funding that would have impact on some of our staff and teams, not only in the Health Board, but across colleagues for the Council and other departments as well. So just to reinforce that point for the board's wider awareness, that's being very closely monitored by our Director of People and Culture, but also by our Executive Committee as well. And then just to advise in a positive sense, the recognition and success that's happened across the Health Board in terms of the improvement in workforce performance statistics, particularly in relation to statutory mandatory training and performance appraisal review. So we continue the journey, but some very positive news there. Thank you.
Thank you, Helen. Colleagues, any comment or question in response to the Workforce Culture Committee report? If none, then can we go next, please, to the Exec Committee report, and then we'll just come back at the end to the Joint Committee of DMP and PPPH. Thank you, Haley.
Yeah, thank you. So you can see from the report that we've had 6 meetings, and there are a number of matters that we've discussed in Executive Committee, which were moving onwards to the various committees, which colleagues have covered a number of points through committee reports through the year. So there are no issues in the report to alert or advise, but I hope you can see the breadth of what we do in the executive committee to prepare the assurance report to committee and board, but also you can have a summary within that of the day-to-day management and operational matters that are covered as well, but nothing particular to alert members to, just open to taking questions. Thanks.
Are there any questions or responses to the exec committee report? No. So we will go finally to there was a joint meeting of the Delivery and Performance Committee and the PPPH Committee, specifically to scrutinise various aspects of our annual plan for 25-26. And so as I invite Robert, who chaired this meeting, to present this report, I would ask colleagues simply to make the connection between the assurance that Robert will give to us and item 3.1 on our agenda when we come to consider and discuss the proposed plan itself. So Robert, please.
Thank you. The purpose of the meeting was to assure the joint committee that the draft annual plan, which is a plan for 1 year, 25-26, was aligned with 3 direction finders: the board strategy, the NHS Wales planning framework, and the draft de-escalation criteria. Despite the fact that the document received was draft, the independent members forming the committee gained such assurance thanks in no small measure to the guidance and clarification received from executive. I noticed that the differences between the draft and the final plan have subsequently been circulated, and although there are differences in detail, in my view, the plan presented today continues to be so aligned. Thank you, Chair.
Thank you very much, Robert. Again, any questions, responses to the report from that joint committee meeting? Yeah. So, well, thank you to all the chairs and all the committee members, as I say, for the enormous amount of detailed work that happens week in, week out by our committees. Appreciated. We move now to item 2, which relates to the consent agenda item at item 5, and this simply gives an opportunity for any board colleague to request that an item from the consent agenda be removed and placed on the main agenda as a substantive item for consideration and discussion. Does anyone want to make such a suggestion? No. So the consent agenda at item 5 stands as it is, and we will deal with it in the way that I explained earlier, which means that we move on to section 3 of our agenda and to our annual plan for 2025-26. The Chief Executive will present this item to us, but we will also very importantly have the contribution of our Executive Director of Planning, Performance and Commissioning, Nicola. But first to you, Nick.
Thank you, Carl. We're trying to present this plan in summary format through this presentation, but recognise that all members will have had an opportunity to look at the detail contained both within the main plan and in the cover report. So just as an introduction, if we can move on, that's okay. Great. So as you're aware, we're in escalation, level 4 escalation, and we are developing an annual plan this year for 25-26. And through my accountability as accountable officer for the organisation, we've written to Welsh Government to advise them that we're unable to deliver a 3-year plan that meets the statutory break-even duty. You will be aware that the board has been involved through a number of different meetings and development sessions and discussions throughout this year in developing this plan, but also I'd like to give you assurance about how this has been developed in partnership across the organisation. and the thanks to all staff that actually contributed to the content of the plan as presented today. The plan's been written in the context of our long-term vision and strategy, and clearly it has been about meeting our duties, both statutory, financial, and in relation to the duty of quality, and to ensure that we get the right balance between developing work around prevention and improving the health and well-being of the population, early help and support, the delivery of primary community mental health services, as well as commissioning secondary and acute and specialised services for our population. There's detail in the plan around the need for us to, at pace, move forward with transformational work and better together portfolio, and the key and role of the workforce and the sustainability of our workforce in delivering this, utilising digital ways of working, and also making sure that our capital and investment plans support the delivery of our strategic priorities. Quality is a big fact and a key thread within our plan and the choices that we've presented. And that is based on substantial work that's been done this year to further improve our quality management system. We'll be taking you through the way in which we have worked through critical actions that need to be delivered under the themes of risk recovery and sustainability. And we will also cover both the assumptions around our provider performance and the commissioning approach that we're presenting for this year. Clearly, we have a very challenging financial position and deficit to manage, and therefore we will be also, Pete as Director of Finance will also be presenting the options around our financial plan. And then finally, we'll provide a bit more information around a meeting that took place of the Joint Commissioning Committee after the papers were cleared for this, with regard to the assumption in our plan for the Joint Commissioning Committee, which is responsible for commissioning both emergency ambulance services and specialised services in Wales. And the approach that we take to governance and risk management is also contained within the report. Next slide, please. Thanks, Liz. So we know we've had a tough year in 24-25, and we've had to take some actions already to deliver against the current year's plan. So as we're aware, we had to take additional actions with regard to the workforce, agency usage, rostering and recruitment freeze, and also that we implemented temporary changes that required engagement on board changes and on minor injury unit operating hours in the year as well. Overall, we've got good provider quality and performance, and clearly part of that was the refresh of the approach that we've done to ensure that quality is front and centre to our integrated performance framework. And you've heard already earlier, it's seen the report from the PECS committee around the work that's undertaken to further improve mental health and disability services, and also the work that's currently in place to improve the position for children and young people awaiting the neurodevelopmental service. The Better Together programme is contained within the plan, really key for us, and we have said all along that we need to consult and engage with the public on the sustainable model for the future in Powys, and you can see further detail in a later slide about that. And then obviously our financial performance in year, just to say that the level of savings we've had to do every year has been substantial, and clearly the key areas of variation around commissioning spend, continuing healthcare, and also flow delays still feature within our plan options that we'll take you through. Next slide, that's okay. So I won't go through this in a huge amount of detail because it's in our cover report, but I just wanted to remind board members of the process and depending on integrated planning process as an organisation, and also just to draw to your attention the opportunities and times we've discussed the content of the options and critical actions that we've identified in our plan. And clearly the issue around the correspondence with Welsh Government I referenced earlier in terms of Robert's question, but we have responded to Welsh Government clearly setting out both in relation to our inability to submit a balanced plan, but also the requirement to confirm our position around signing of LTAs with NHS Wales organisations as well. So those are two areas I want to particularly draw out. And I think in terms of Welsh Government scrutiny feedback, we have shared our draft plan with colleagues in Welsh Government, and also on the 10th of March, there was a scrutiny session held with Welsh Government where we took them through the key components of our plan. Obviously, we're aware of the need to balance the strategic risks, quality, performance and finance. And just to reiterate to the group, that there has been consistent messaging from Welsh Government that we need to meet as a minimum our target conjunct total, and there's no further funding available to support the NHS beyond that in terms of planning assumption in Welsh Government. I'll hand over to Nick now, if that's okay, to cover the approach and strategic framework.
Thank you, Hayley. So the board has had clear oversight and direction of the development of the plan, meeting as the chair outlined earlier. One of the elements of the board's purpose in terms of setting the direction for the organisation, and the strategic priorities were refreshed within the context of our agreed strategy, which remains in place until 2027. And our strategy is obviously based on our demography, health needs assessments for our particular population in our rural county of Powys. It builds on the 5-year plan that the board approved last year and clearly outlines the development of a better together portfolio with the case for change that the board has had oversight of. As you'd expect, the plan has been developed in line with the strategy, the NHS Wales planning framework, the allocation letters, our draft escalation criteria, the performance framework for NHS Wales, and clearly responds to the drivers of our financial deficit, which are well understood by ourselves and the board. The board agreed the themes of risk, recovery and sustainability to ensure that we continue to manage our strategic risks and our highest impact areas in terms of quality, that we respond to the financial deficit in year in the recovery space, but clearly that we're outlining that future vision of sustainability as well. And within that, we agreed a set of critical actions, which I'll come on to shortly. The new priorities set up by the Cabinet Secretary in the planning framework are also reflected, particularly around women's health, tackling diabetes as a key step in population health, and the enabling actions for efficiency and productivity. One of our de-escalation criteria, draft de-escalation criteria, relates to the need to lay out our what Welsh Government call clinical services plan. So our plan for our how we will provide efficient services in the future for the health board to be sustainable and meet the needs of the population. This slide summarises. Sorry, I can have the next slide. I've got all my screen, so sorry, you can have the next slide. This slide summarises the governance model for the Better Together portfolio, which oversees this important part of our work, with clear governance and design in place, reporting to the executive committee, and then through the PPH committee to the board, as we've heard in the previous reports. There's been a lot of work on the phasing of our future models and how we will work through the plans for those in engagement with our stakeholders and our population. And it's been agreed that the plan outlines that in 25-26 we'll be working through those models to community and frailty and mental health as the first phase, and outlines the engagement and consultation timeline, taking into account that the NHS is subject to clear guidance on consultation and engagement. Can we have the next slide, please? As you'd expect, we have a number of statutory duties, and the duty of quality, again, we've discussed that in the context of the PECS report earlier, but is absolutely key to everything that we do. Quality is everybody's business and is a golden thread through the plan, and under the leadership of the Executive Director of Nursing Quality, the focus in the last year has been on that systematic total quality management system. Again, we heard an element of that in the PECS report, particularly relating to patient experience, but it is a holistic total quality management system taking into account all of those domains of quality in a steep framework. There have been improvements through that which are outlined on this slide, and clearly aligning to the way that we manage and monitor performance and quality together, as well, taking that forward through the framework that the board agreed towards the end of last year. And one of the other key achievements, key elements of the plan going forward around embedding the incident management framework. So taking together those themes of risk, recovery and sustainability. So if you have the next slide. We have prioritised, so the plan outlines all our improvement actions and deliver across the whole span of our work as a health board. Obviously, that is complex and far-reaching, both from a provider and commissioner point of view, in terms of our population health responsibilities and our service delivery responsibilities. And we respond to all areas of the planning framework. However, given where we are in terms of escalation for finance and planning, but also equally where we are in routine monitoring for all the other domains of the Welsh Government escalation framework, we have agreed a series of critical actions to make sure that we are seeking that further improvement in those high impact actions in terms of the quality of our services or our key strategic risks. In the recovery space, particularly in our provider and commission services, a range of key critical actions, and then take forward together towards the sustainable model, equally critical actions around that. Can I have the next slide, please? Moving towards some of the tactical considerations in the plan, the board has considered both at board development sessions and in the joint committee meetings that again we discussed in the board assurance reports, the provider performance, and again the board receives a report on this at every meeting, including today later on the agenda, where it's clear that our provider performance is generally good, and the assessment for next year is that we can maintain that with either reasonable or high confidence, apart from fully meeting the ministerial measure for neurodevelopmental services for children and young people. And board members, again, through the performance quality and performance reports, will be aware that this is a service that's been in escalation this year, and is likely to remain in escalation at least for the first part of next year. However, there has been significant improvement both in the service model and the operational management of that service, but also in terms of a reduction in waiting times. And the plan includes maintaining that improved waiting time at 104 weeks during next year, with further improvement dependent on Welsh Government funding. The next slide, please. In terms of commission services, as Hayley said, we have agreements in principle with all our NHS Wales providers as mandated for allocation levels. and we're just putting the finishing touches to the actual LTA agreements. And we're pleased there's been some movement in the way that we're managing those relationships, with particular controls and mitigations agreed with the majority of our providers if there is further tranches of centrally funded planned care, and working with Cyntar, Morganwg, really transparently over some of the overperformance issues that have transpired on our LTA with them. In terms of the NHS England situation, again through the performance reports, members will be aware that there's differential performance in commission services, and therefore in this plan our tactical commission and assumptions are laid out on the slide, both in terms of understanding our plans for our two main integrated commissioning system performance assumptions and plans, and considering the assumptions that we will make in terms of meeting the ministerial measures that are applied to us within NHS Wales. Over the next slide, please.
Okay, thanks, Nicola.
Hand to Pete.
Yeah, good morning, everyone. Pete Topgood, Director of Finance. So I'll just take you through at a relatively high level the financial plan supports the priorities, the action and details as Hayley and Nicola have already described. I'm going to take you through the summary table on the right-hand side of this slide. There's clearly been a lot of work identifying the impact of inflation, growth, the opportunities within our position to form the basis of this financial plan. So our starting point of the plan is our current assessed underlying deficit of 30.6 million. The underlying deficit is based on our forecast outturn performance for this year, which is 15.8 million deficit, and then adding back those non-recurrent factors such as funding and expenditure benefits and other areas to build up the underlying deficit. There's then been a complete and thorough analysis of the inflationary pressures on our plan. Those all relate to increases in prices. They're assessed to be 8.5 million. Then an analysis of the forecast increase in growth and demand for our services. This means increases in number of activity. Will include areas such as continuing healthcare, where there's an assessment of the increase in number of packages that are likely to take place. And that's been assessed at 15.3 million. We include a modest £1 million investment fund within our plan. That is to support any spend to save activities and also any unforeseen other cost pressures. That's in as £1 million. We then have our Welsh Government increase in our funding allocation, the 1.77% uplift. That gives us a £6 million benefit. And within our plan, we've identified a savings target of 2% recurrent, that is 7.3 million, and 1% non-recurrent, 3.7 million. That gives us a total savings target of 11 million within the plan. Our target for this year was 9.9 million. We've actually delivered and exceeded against that target in this financial year. So it gives a level of reasonableness around the level of savings that have been set for the next financial year. Excuse me. Also, to explain the difference between the 2% and 1%, 2% being recurrent is a realistic level, and the 1% non-recurrent also recognises some of the actions that we've taken towards the end of this financial year to help deliver our position. So that gives us an in-year sort of additional financial challenge of 7.8 million and gives us a starting point financial plan deficit of 38.4 million. Just to note that within our plan, there is an element of Welsh Government conditional recurrent funding. That's assumed to be available to us next year. And just to highlight the financial risk, if there's a significant increase in our English elective activity, which could be a potential risk of around circa 8 million. So the starting point of our financial plan is at 38.4 million deficit. Clearly that is very worrying and very challenging for the board. And clearly it's a long way from our 12 million target control total, which is a minimum expectation around our financial plan. So if I just move forward to the next slide, the board has identified a number of additional action areas to be taken to improve our financial plan and our financial performance. They can be grouped into, they're included on the table, but they can be grouped into three clear areas. First area being that we ensure that we commission all of our providers to deliver against the Welsh performance targets. The second area is focusing on the challenge within our system in relation to delayed transfers of care. They have an impact both on hospital delayed transfers of care and social care delayed transfers of care. It's clearly an area of focus for ourselves and Powys County Council as our partners in this area. Currently, it contributes significant cost to our system. That cost is on the back of an inefficiency where there are delays. So it's an area of opportunity for us to improve. And we've set a significant target in that of 5 million based across the use of reprioritising the funding that we received in certain areas to go against the cost of delivering the mitigation in this area, and also work to improve and action the benefits. So just to explain, if we can really reduce our delayed transfers of care, that will reduce our length of stay, that will free capacity within our beds, that will mean that we can repatriate people back from our other providers, that mean that we will pay less to those providers, particularly in the English system where any delays where people stay in community beds or in district general hospital beds results in a significant cost that we pay for. Clearly, if those are then released, it's financial benefit. So that's the second area of focus. And then the third area is in relation to the Joint Commissioning Committee. Currently their plan has been set based on a 4% uplift on our baseline position. We're still working on an action to deliver that to 1.7% as per the funding uplift that we've been provided. So these areas, as identified at a high level, there's been a lot of work to identify the potential financial benefit in relation to those actions. They're detailed on the table, and potentially if all were delivered at that level, that could take us from a 38.4 million deficit I referenced earlier down to a position of circa 16 million. Clearly, that's still not at our target control total, but it's as close as we can potentially get to without seriously changing the dynamics and the balance between quality, safety, activity, outcomes, and finance. It is worth noting, though, that these figures are, although based on a thorough analysis, they are indicative. Actual delivery in these areas will be based on the action taken and the output of that action. That will be closely monitored as we move across the plan, and that will have the impact on our financial forecast. I think I'll stop there and I'll pass back to Nick for the next slide, please.
Thanks, Pete. So just a little bit more focus on the Joint Commissioning Committee. One of our requirements is that our plan aligns to the Joint Commissioning Committee's plan and to give assurance to the board that it does. So we acknowledge in our plan that the Joint Commissioning Committee agreed collectively last week that following discussion of a number of scenarios that the uplift, the plan includes that uplift of 4%. But as Pete said, there are ongoing which particularly for us play into our improvement options around further work to improve towards 1.77%, which obviously all health was funded for in the allocated letters. There were a number of risk assessments and choices made within those scenarios, and on the basis of that, it's been agreed that no new areas of specialised services will be commissioned in year by the Joint Commissioning Committee, and that a number of areas that were potentially further risks, it's been agreed that health boards will implement going forward. There were 8 areas of specialised services in that, and they're very highly specialised. And for us, our assessment is that the impact of that would be quite minor, but obviously we'll play our part in terms of commissioning those highly specialised services. In our plan, you'll also see in the commissioning for value delivery plan work on referral management, particularly into English providers. Again, Joint Commissioning Committee, biggest provider, commissioner of services from England for Wales, and we very much looking forward to working with Joint Commissioning Committee on that referral management and sort of testing those ways of working from a health board point of view, whereas previously maybe the focus from the central point of view. So very much looking forward to testing that new way of working with the Joint Commissioning Committee in 25-26. As you could, our RAN plan is an integrated plan. Sorry, if you have the next slide, please. So turning to the workforce elements of our plan, workforce is our workforce is our greatest asset in terms of commissioning and providing services for the population of Powys. And the plan outlines our holistic plan responding to the NHS Wales workforce strategy to improve both the availability of skilled, well-trained workforce, modernising our service models and workforce model, ensuring that we're doing everything we can to recruit and retain our skilled and expert staff across all areas, and supporting all of our workforce with their well-being. So I'm not going to go through this slide in detail, but the workforce chapter outlines all of those really important areas, as well as the links to our transformational work on Better Together to become more sustainable. Go to the next slide, please. And I'm going to hand to Hayley just to finish off the presentation.
Thank you. So just a couple of additional points from me. Clearly, this plan in the detail is obviously attached, and we've just given a summary of key issues within it. Clearly, how we deliver this will be a key consideration, not just as an organisation, but also in partnership. And I think I should say that there's reference to partnership working in our plan, particularly work that Powys County Council has commissioned recently to review adult social care. Just for clarity, we haven't assumed any savings in the plan from that particular stream of work in our current financial plan. I just want to be clear on that. And also in the assessment that Pete said, and there's a lot of detail, but if I give just one example, when we've assessed the demand, the inflation and growth, as an example around continuing healthcare, although you'll see a £500,000 improvement target against that, we have also increased the budget to actually deliver against the expected growth in demand around continuing healthcare. Those are just examples. There's a lot of detail behind this presentation, but I wanted just to draw a couple of those examples out. From a governance point of view, clearly the structured assessment last year, but also the draft structured assessment, which will come through with the appropriate time to the board, is reflecting generally good governance arrangements for us, and we've also had a good feedback on our internal planning processes as well. And I just wanted to bring that to the board's attention, as well as the work that we've done to date to reflect our risk appetite, but also the ongoing work we'll need to do to update continuously our corporate and strategic risk register in line with the plan that we as a board take forward into the new financial year. So clearly today, this is in the context of knowing that Welsh Government have set a very clear direction for us of what they need us to do to have an approvable plan. So my recommendation is that the board considers this plan for submission to Welsh Government, and clearly there will be ongoing dialogue with Welsh Government around our escalated status, but also the detail contained within our plan. And we have to submit to Welsh Government by Monday, 31st of March, in line with all of the health boards in Wales. And just a final point, this has been a substantial amount of work for the organisation, and I just wanted to thank all members of staff who've been involved for their substantial efforts in being able to present this plan today.
Hayley, Nicola, Pete, others, thank you so much for that whistle-stop, very heartily, I thought, whistle-stop tour of a detailed plan. And certainly, I think we as a unitary board, Hayley, would want to echo your thanks and appreciation for the very large
amount of skilled and professional work has gone into developing this. I also, as chair, just want to support some of the comments that Hayley and Nicola have made in terms of our role as a board. Clearly, we are here today to consider the final proposal in terms of this plan, but as has been mentioned, we have played a very key role as a board in steering the shape and content of this plan in the various development sessions and so on that have been mentioned already. And we take seriously the issue of board ownership in relation to the plan. So I think that's an important point to just to support. And so before I open this to discussion, I'm going to invite Nina to comment. Anything from your perspective, Nina, that you would like us to take into consideration?
Diolch yn fawr, thank you, Chair. I'm Nina Davis. I'm attending as Associate Director of Powys Teaching Health Board here today. Thank you very much to Hayley and to colleagues for the presentation, the high-level presentation. That's very helpful, and note the comments and some of the things that have been pulled through. I think it's really clear that we note the risks throughout the budget plan that has been delivered here today for 25-26, and also the difficult decisions that will need to be considered as part of that as well. I think for me, what really comes through is the importance of joint working as well between Powys County Council and Powys Teaching Health Board, between many of the areas of the budget plan that has been presented here today. A couple of areas of comment and query, if I may, around continuing healthcare. I note the increasing spend and budget given to this area, and noting the ageing population of Powys, that probably is to be as expected and as appropriate. And it reflects the kind of what is being seen elsewhere, with people presenting later and with greater levels and complexity of need as well. I also note the efficiency target, I think was the phrase that was used, and so I just wanted to seek assurance, on how that would be delivered and that it wouldn't be impacting on patients, etc. So just if we could just have some high-level detail on that, that would be appreciated. I also note the targets set against hospital flow and discharges, with reference also given to adult social care. I think, Peter, you've referred to a £5 million target, so I just wanted to query how that target has been set, and there's a high-level plans for delivery on that at this stage as well. I note reference to utilising existing funding differently, in particular RIF funding. So I agree that it's really important that all funding received needs to be targeted at highest priorities, and RIF funding, for example, needs to be targeted at achieving the priorities of the Regional Partnership Board. And it's really important that we ensure that we focus limited public resources on the areas that will have the greatest impact as well. I do note this is partnership money, and at present there is no discussion or agreement on what is going to be allocated. So obviously this is an area of focus and of work ongoing. Just noting the importance, of prevention and innovation in this area as well. And then finally, Hayley, you picked up, and I note throughout the board, the paper agenda we got in front of us, reference at a few points in the plan to work we've got currently ongoing in terms of an adult social care diagnostic. That work is concluding in the next couple of weeks, and the aim is to implement in 25-26, with efficiencies being put into our financial resource model for 26-27. And I welcome the involvement in EPTHB colleagues throughout the diagnostic work, and note that we have workshops together on the 4th and the 11th of April. So in the next couple of weeks, we'll be looking at the findings of that diagnostic, and then looking together about how we can work together to implement, make sure we can do what we can together in this area as well. So I hope that's okay, Carl. Just a couple of comments and queries. Thank you.
That's really helpful. Thank you, Nina, and much appreciated. And I will make sure that within the discussion, we don't lose the points that you've made and the questions you posed. So thank you for that. I don't want to put you on the spot, Katie, but I just wondered also at this juncture whether you might want to share any observations with us for our consideration before we go into discussion.
I should introduce Katie as Regional Director of Llais, the citizen voice body here in Powys.
Thank you, Carl. Yes, I have got a couple of observations to make. Just to reiterate that Llais is an independent statutory body, and we're not part of the decision-making process here today. So from the point of view of us making observations on this paper, there is one particular element, recognising it is contained within an overarching paper for agreement today by the board. But the concern, again, that I shared at the board meeting in January is around the commissioning times and the plan to commission to NHS Wales targets. And that I find really quite disappointing, recognising the challenges that this health board, other health boards and other public sector bodies are under financially. But as I shared in January, one of the things that we hear all the time is the impact of patients having to wait for services, the impact on themselves, on their families, on their carers, on their mental health, on their work. And, you know, those things have changed since I shared my concerns with you in January. And I think, you know, one of the other worries, I suppose, and a bit of sadness is that this proposal, in effect, perhaps is levelling down rather than levelling up. The aspiration, I think, across Wales is to actually improve waiting times, and the impact of this decision today brings it down to 104 weeks, which admittedly is within the Wales targets, but we know that there's a significant percentage of the population who are accessing services far quicker and on faster waiting lists. So I don't really want to say a huge amount more. I think we discussed in January the potential impact on between 2,000 and 10,000 people. I think, you know, if this decision were to be taken, there's significant amount of work around supporting individuals and families and communities in waiting for these access to services. And I suppose fundamentally, my concern in Powys is that this is a bit of a short-term decision that has long-term implications.
Thank you very much, Katie. And once again, we'll certainly bear those observations in mind, and I'll be looking for a response to those during our discussion. So thank you very much. Colleagues, please come in with questions, comments, and so on. So we go to Ronnie, Simon, and then Steve.
Thank you. I think this was a very helpful presentation, and I don't argue with the detail of what's here at all, but I do have a question around deliverability. Hayley, the sixth bullet point of your first slide related to a set of critical actions that have been identified. And those were further developed by Nick. Some of these are really big issues like diabetes, mental health transformation. And mental health actually is almost a system itself. The problems, that the issues there are huge. Optimizing inpatient pathways, bed utilization. So my question is, later on in this agenda, we will be further considering the issue of risk. So what's the risk to us as an organization if we fail in one or more of these critical actions? Thank you.
Yeah, thank you. I'll come in first, and if my colleagues want to come in, we can signal. So that is one of the key issues that we've been grappling with in setting this plan, which is the overall delivery across the whole of the plan for the organisation rather than specific individual critical actions. And you heard earlier around the need to balance business as usual, delivering what we need to do day to day operationally, the capacity to transform and to change. And in our assessment of this plan, that is why we've set those critical actions. in the way that we've done, because it's our best assessment that that is what we are capable of delivering as an organisation in this year. It's not without risk, and clearly individual actions have different risk profiles, but that's been the main focus of the executive team's discussion in supporting, and in the discussion that we've had informally as a board as well, is the overall assessment of deliverability has been set, which is why we've set the plan as we have done, that initial £11 million savings and additional critical enabling actions to actually give us a financial improvement. So it's still overall a high risk plan, Ronnie, overall, but I think that in terms of the assessment of the individual critical actions, there will be a range of confidence in terms of our delivery around that. So I don't know, did you want to come in as well?
Yeah, thank you. I just want to show the board that we've had a lot of discussion, both with yourselves and as an executive team, around that balance of ambition and deliverability. It's been really important to us that we didn't just go into the recovery and sustainability space, that we had that theme of risk, and we responded to our main strategic and service risks as well. And that's why mental health transformation and operational improvement, continuous operational improvement is one of the critical actions. And I just want to thank you really for picking mental health out as an example. We are a major provider of secondary and primary mental health services for our population, as well as commissioning significant amounts of tertiary care through the Joint Commissioning Committee. We take that really seriously, and that is why we highlighted it as one of the critical actions in the plan, in that risk space, also in the sustainability space. We know we've got a journey to go on to become fully sustainable in mental health. So there are limitations of an annual plan because we can only lay out the actions for the next year, but a number of these actions are further planning, setting us up well for the transformation in future years as well. So just wanted to thank you for picking mental health out, and particularly Ronnie.
Content, Roddy?
Yes.
Thank you.
Yeah, so just very briefly, hi, I'm Elaine Lawton, I'm the Executive Director of Primary Care Community and Mental Health. I just wanted to clarify as well, with a number of these critical actions, this is our plan for this year ahead, but we've also been working on a number of these critical actions for some time. So a number of these are not starting right now. Some of these are continuing a journey that we've already been on at least for years, some places for longer. And this is really focusing and charging ourselves to take these next steps in a really focused and purposeful way.
Thank you.
Simon Wright, independent member at university. I wanted to explore a little bit further the English provider commissioning recommendation, recognising it's arguably the biggest cost pressure for the board, and therefore something that we do need to have try and have some control over. Also recognising the consistent and clear messages from Welsh Government on commissioning and to commission what you can afford, and even with these proposals, which will have significant serious impact on the population of Powys, are above what we can actually afford. They don't get us to the control target that Welsh Government was. So there's a few questions and reassurances I'm seeking. We were hearing in quite recently with a similar proposal. So just understanding, and Welsh Government stepped at that point with further funding, so understanding what's different now in terms of this, bringing it back round at this point. Is this a service change, and will it require the level of consultation for service change, or is it something that can move more quickly? Would be good to understand. And critically, where is our confidence on the deliverability of this? How far advanced discussions with those English providers, and kind of what happens in the clinical space if clinicians in England, say no, this patient Powys is becoming. So just a number of things just to understand. And then going back to the question asked previously, does that then mean 6 months down the line in terms of Welsh Gov saying you have to deliver to your plan in terms of our confidence at this stage and submitting the plan with quite a lot in it, which feels to be needing to be worked through and with some levels of risk.
Thank you, Simon. Shall I ask Nick to go first and then Clinical Director, perhaps Kate, did you like to come in on the clinical discussion?
Thank you, Hayley. So if I wrap your question with Katie's comments as well. So healthcare is a devolved matter. It is legitimate for devolved administrations to set ambitions which are deliverable and affordable in terms of the quality and performance ambitions for the populations. Our planning assumption in this plan is to set activity levels across all our providers that meet the ministerial measures. And again, we've appraised the board of the conversations that we've had with Welsh Government, various correspondences we've had, our de-escalation criteria and the financial and quality drivers of the plan, and that ambition to achieve a figure towards target control total. It isn't a planning assumption that we make lightly, and responding to some of Katie's comments, there's been a lot of discussion with us as a whole board around our balance of quality and financial duties in that space. However, some of those directions we've had are really clear. Turning to your sort of detailed parts of your question, our conversations and our assessment as a health board, because it is our responsibility to make the assessment, but obviously we have tested that with lice, is that this is not a change that will be subject to the guidance on engagement for service change. The services remain in the same place, the flows will remain the same, patients will access the same clinical services, and as I say, we are planning to meet the ministerial measures that we're all subject to. What is different is that it's not an in-year change in the context of our plan, so that planning assumption is for the whole for next year, setting those activity levels with our providers, which is our responsibility as a commissioner. In terms of deliverability, we are still testing that with the providers, it would be fair to say. I have written out to them and we're meeting with them starting tomorrow to test those assumptions. But our intention is we flag that we'll give them more time to plan to put this into place in order that the operational and strategic consequences can be managed in that balance of risk between the commissioner and the provider. With regard to clinical prioritisation, I'll let Kate comment. But again, similar to discussions we have in January, would clearly laid out that this wouldn't affect cancer patients, people under the age of 18, or those prioritised by their clinician as urgent, and we would expect the clinical prioritisation processes to be the same as they always are. So clinicians accept the clinical governance for that referral and triage referrals when they come in. But again, I'll let Kate comment on that further. And then in terms of in-year, this is an issue that is going to be with us for the medium term, at least in terms of those different expectations that the devolved administration set. So something that we'll have to continue to talk to the board about frequently, I'm sure. But I'll hand to Kate now in terms of clinical elements.
Thank you.
Yeah, thank you. So Kate Wright, Medical Director. So yeah, thanks for a really important question, Simon. So I think, as others have said and you have highlighted, it is really challenging and it can't be called a quality-led decision. It's not comfortable. The uncomfortable part is we already have inequity across our system. So some people in health are waiting way longer than others. So we're starting from a position of inequity. But as Nick has said, given that this is now more planned in here and there has been more time for dialogue with the services in England, then the hope is that that will allow for more assurance in terms of the systems processes in place. The prioritisation will, as always, that won't change. That will be down to the receiving clinicians, the receiving teams using their existing systems to prioritise. And that will need to be watched very closely, clearly. As Nick has said, then children with cancer patients and urgent care will be excluded. So this will be patients with non-urgent treatments. And it comes down to balance of risks, really, fortunately, which as we always do. So there is not that risk, it's not a quantity-led decision. We know, though, that there are people that are currently referred into the system that could have different methods of treatment. So that's why referral management is also a really important part of our plan. And we're already putting some simple systems into place in Powys. So musculoskeletal work is going really well in terms of actually some people don't need to go into commission services and can have a different treatment. We've got a brilliant dermatology project whereby simply changing the way we make a referral is cutting down the number of people needing to be seen face to face. So there's more work around this in terms of looking at the way we practice, which actually is improving care and improving outcomes. So I hope that answers some of the question.
Thank you. So we've got Steve. Kirsty wants to come in. We are giving time to this matter because it's a very substantial and a very important matter on our agenda today. So I'm very happy to give it the time it deserves. We may well go up to our break on this matter and then hope to catch up after the break. But it probably does mean as well that if we can be as concise as possible, both in the in all the contributions, that would be helpful. But not to stifle anything. Thank you, Steve.
Thank you. Can I also echo, the thanks to the executive colleagues and their teams for the amount of work involved in this plan. I know from personal experience it's a lot of work and it's a really helpful document. I just really want to build, I suppose, on points that Ronnie and Simon have already made, and particularly with a focus on the financial plan. The last but one bullet point in the recommendations asks about us to approve this plan, noting the underlying deficit of 38.4 million, with agreed actions identified to reduce this deficit to a potential 16 million for submission to Welsh Government. We've already referred to some of the delivery risks around elements of this plan, and Pete, you've referenced to the items in the second table as being indicative. So I'd just like a bit more clarity on when we are going to get to a point where we're clear on what the financial plan for 25-26 is, because it would be very important for us as a board to be clear on that in terms of being able to monitor progress throughout the year, because I'm not sure at the moment whether it's 38.4, 60 million or another figure. Thank you.
Yeah, thanks, Steve. So it's a really important point, and quite difficult one just to give a black and white answer to, I guess, but it's really important that as we work through this, the board are aware that the scale of our financial challenge, the ambition and the effort needed and the risk within getting to that 38.4, which is the reason why we're referencing that. I think what we're trying to be clear on is that ambition to improve on that in terms of financial performance, to get to a position as close as we can to type control total, and those areas identified with the potential to get us to a position of around 16 million. But cannot say that is a definite figure at this stage, given all the comments that we've made. So I think we're at a point where we're recognising the 38.4 and we're recognising the action areas and ambition to get to that 16. So that doesn't give a figure in between those two as a figure for our plan. It's stating those two, as I've just said. So I guess that's subject to any more comments or agreement within us as a board in terms of how we describe that. It's going to be different.
So I suppose I'm just looking for an understanding of a process to review progress towards delivery of that number. Is that something that's going to take place within a short period of time, or is it?
I think it will be.
How do we get clarity as a board on for this year as well?
Yeah, so I think that will be an ongoing and iterative process whereby we've already done the works to try to then find the action in those areas, and then clarity in terms of delivery will be updated on an ongoing basis.
Pete, just whilst we're on that, so sorry, Mick, if I may. So just thinking of Nina's comments earlier, whilst we're talking about money and finances. So Nina raised with us a query around how has the 5 million target been calculated in relation to social care, and also how has the CHC efficiency target been arrived at?
Yeah, sure. Okay. Very high level. Continuing healthcare, we're forecasting to spend circa 35 million this year. In our plan, we've got an assumption that that spend will be circa 40 million, so a £5 million increase in funding to cover the cost of price inflation and forecast additional growth. So that is an uplift far in excess of other areas within our plan, noting the impact of that, both in terms of the needs of our population and financially. The £500,000 savings target is lower than the 3% for all other areas. It's circa 1.2%. That is linked to both the national programme of work under the Value and Sustainability Board, which has 7 key recommendation areas which we are part of, which will aim to bring some benefit. So the target sat in that area is relatively low. Of course, there's an intrinsic link then through to the delayed transfers of care. As we know, every delay in a day longer in hospital leads to deterioration in terms of an individual's health and well-being, which can then trigger further additional needs for continuing healthcare, which then adds to our cost pressure. So anything we do to improve in that area does have a direct link through to CHC. So there's a bit of a circular flow there. In terms of, so we do know at the moment currently within our system, there's a failure in the system due to lack of capacity, due to availability of workforce, etc. That total cost of those delays on both health and social care is forecast to be circa 18 million in this year. So that's 18 million pounds worth of inefficiency. Any improvement we make in this area will lead to financial benefit. The target of 5 million is split across one, the use, repurposing of use of funding, including a reference to RIF. That's part of the 5 million. And also that improvement in terms of reduced length of stay. As I said earlier, if that length of stay is improved, we can repatriate people back from other providers on a more timely basis. That will include our English providers. We're spending circa 4 million in terms of delayed transfers of care in relation to social care delays, which could be saved if that length of stay reduction is achieved. So clearly there's a clear link here between plans with our local authority partners. They'll be planning to provide the level of social care as needed for the population. We know that's challenging. We face our own challenges, so it's working through it together to identify those efficiencies to help deliver that. So the mix of 5 million based on funding action is relatively proportionate compared to that 18 million pounds of inefficiency that we're currently experiencing.
Thank you, Pete. So Kirsty wants to come in, and I know that Mick does as well. Katie, I'll come to you. Katie, is it a question rather than a participation in the discussion?
I just wanted to come back on Simon and Nicola's comments about the service change, but I'm happy to leave it until the end.
I'm just thinking of, you know, kind of the participation in the discussion, as it were. You know, we've had your initial observations, but okay.
But I just factually want to say something important, if that's okay.
Okay, thank you. Kirsty, let's come to you. Kirsty, also thinking of your role as chair of RIF, and also picking up on Nina's observations earlier, that there hasn't to date been any discussion about the reprioritisation of RIF at the RPB. So you may want to pick that up or not, but whatever, you want to come in anyway.
Yes, certainly. Well, Nina is quite right. There would have to be agreement at the Regional Partnership Board with regards to how RIF is allocated, and that has not happened to date. So that would be a risk associated with that particular aspect of the plan.
Is that discussion planned?
The RPB met last week when I was away on leave. My understanding was decisions weren't taken at that stage, so the next RPB will be in the next quarter.
Okay.
I wanted to raise two issues. Firstly, we've said a number of times this morning, haven't we, that the very, very clear steer from the Welsh Government is to commission only what we can afford. And on the face of that, that's not an unreasonable expectation of an organisation, is to spend the money that is available to the organisation. So on the face of it, that's not an unreasonable expectation. But obviously there is huge disquiet and discomfort being discussed this morning about the consequences that will have, particularly in commission services across the border, where Powys patients have been fortunate to experience quicker waiting times in other parts of the county. But given the proportion of our budget on commissioning, I would like to understand what alternatives to that savings line have been considered, and what would the consequences be for services in Powys if we took the decision not to proceed on that basis, but would have to, in line with the government's expectations, change our delivery or purchasing of services elsewhere. So I'm interested in understanding the consequences of not taking that decision today. We talk about consequences, we're all very clear and uncomfortable about what the consequences are, but what would be the consequences of not? And I am particularly concerned about what that would mean for primary care. As Vice Chair, I have a responsibility around primary care. We've not talked about primary care this morning, although it is an absolutely crucial aspect of our plan. And when we think about the services that our population use on a daily basis, the vast majority of our services and our contacts are actually being delivered in primary care with our GP colleagues, in our optometrists and our pharmacists and in our dentists. So what I'd like to understand is, does this plan give us the opportunity to enhance primary and community care, which I believe is absolutely a necessity if we're to deliver the services that meet the local people's aspirations, and whether we have sufficient resource allocated to primary care to realise our aspirations in that area.
Thank you very much, Kirsty. So just as an indication, and Hayley, you might, I don't know whether you want to respond to Kirsty or invite executive colleagues to do that. But just as an indication, I will ask Katie to share the additional information with us. Then we'll go to Nick.
Just to help you note it down, the point I wanted to make has been covered, so cross me off your list of people.
Okay, thank you. And in the absence of an absolutely burning contribution, we'll probably then move to the recommendation. So, Hayley.
Oh, apologies. Right. Okay. So just in terms of the consequences, I mean, when we look at our resources and how we spend our funding overall as a health board, we can't avoid looking at our commissioning services spend, because we spend 40% of our budget there. And that's absolutely right. Your points around primary and community care, what we're trying to do is balance this also with our statutory responsibilities to improve health and well-being. And clearly, when we look at where we're spending our resources, whether that's at the acute or specialist end, we're spending more money on that than we are currently in relation to the other areas of the pathway, which, as we said, the majority of the population will and does access. So the consequences would be severe if we were to choose to protect one part of the pathway over another. Severe in the sense that we would still need to bring options to the table to actually deliver improvement financially. So I just wondered, Pete, whether you wanted to just give an overview of the areas of options that we've discounted in bringing this to the board today. And I think that I'll pick up a few additional points then as well at the end, if that's okay.
Yeah, so it's a really important point, Kirsty, you're right. So clearly, the resource we put into primary care, community care is really important. The number of contacts we have in those areas is far higher than it has in other parts of the system, and that is really important to recognise. So some of the sort of the other actions, those sort of more blunt actions, if you like, we could put an immediate stop to all premium rate cover, all agency, all locums, all bank, all overtime, which would mean we'd have to totally contract our capacity, and that would have an immediate impact on our population in terms of being able to care for them in Powys. That would have an impact on community, that would have an impact on primary care. So that has been discounted. We do spend a significant amount on variable pay, circa 12 to 14 million a year. If that was stopped, that would be a saving, but the capacity, the service impact will be so significant that it's been discounted. That's probably the best example to give. Other than that, just total stop the spend, stop the services. Those are the other things that have been discounted.
You content, Kirsty?
I'd like some assurance around the resources available for primary and community care, and whether the resources that we have been able to allocate will allow us to fulfil the actions in the plan.
That Elaine?
It is part of the plan. We have included the delivery. You used the word enhanced. I would say we've protected primary and community care delivery in relation to the proposals that we've got for this financial year. But clearly the work that we'll be doing around the future model, Better Together, and the point that Nina raised at the start as well about the importance of the local authority and ourselves working together between the Sustainable Powys and Better Together. There will be other options later in the year we'll need to consider about the future shape, but we have protected community care.
Thank you.
Mez, did you want to add something?
Yes, please. Yeah. So I just wanted to sort of, come in. It's very hard, isn't it? And the more many, the demand really in secondary care has been growing, and actually with a growing ageing population, the likelihood they would grow as well. So it's that important in terms of primary care, but also shifting left in terms of populations. What we see in the healthcare is a reflection of the health of our population. So the healthier the population is, really that reduces in terms of demands as well. So and in terms of the plan, we have got a prevention strand, but in the future, as part of the sustainable model, we will need to increase that prevention element. And also, you'll probably hear in the media around life expectancy and healthy life expectancy. There's sort of new data out that shows that there's been a further decline in healthy life expectancy. And what that means is the number of years we live in good health, which is different to life expectancy in terms of average number of lives sort of lived. And that's something I think as we go forward that we'll need to put greater attention to as well, in terms of what are we doing to support and keep our population sort of healthier, to delay people developing conditions, and when they do develop conditions, that we support people to manage them well in primary care.
Katie, you wanted to share some additional information with us.
Yes, sorry, Chair. It's just really, I think, a point of clarification that we do need further discussion on whether this constitutes service change. My gut is it doesn't, but regardless of that, we will be looking at looking to ask for a quality impact assessment and mitigation plan, but the devil will be in the details, so we do need a further conversation about that.
Thank you. Thank you. So, yes, please.
Sorry, so I'd just like to make a comment that obviously we've had some really discussions this morning that are difficult. We're having to recognise that as a board there are some really difficult choices that we're having to take. But I'd just like to offer a bit of a balanced view really about our focus on quality and our focus on prevention and well-being. So I think if you look at the critical actions that we've addressed and even some of the things that you've raised, Pete, around reduced length stay and delayed transfers of care, what we are addressing here is a quality issue. It is about doing the right thing for people and being able to ensure that actually people are not delayed in hospital, people are not having a long length stay that contributes in the long run to their ill health. But also, I think it's really important as a board that we recognise that actually quality is underpinning our critical actions in our plan. If I look at the critical action for neurodevelopment services in children, it very clearly says that we are going to develop, design and implement a children's service that is family and child centred. And I think if we look at our actions throughout the plan, there is a person-centredness to that. So I just think I would be remiss of me, Chair, not to draw out that we need to have a balance here. We are making some really difficult choices that we have to make, but we are really, really focused on sustainability, long-term health of our population and well-being, and that quality is underpinning our plan. And I think it would be remiss if we didn't recognise that.
Really important point, Claire. Thank you very much for making it, and I think it's a crucial point on which to end our discussion. And so we will move to the recommendation. The recommendation is in several parts, but it holds together as a composite recommendation. Given its importance, I'm going to read it out, and that's that we recognise that, as supported at the board's in committee meeting in January 25, the accountable officer informed Welsh Government of the board's inability at this time to develop a 3-year plan that meets the statutory break-even duty, and therefore an annual plan has been developed for 25-26 in line with the NHS Wales planning framework. We're also asked to recognise that the plan seeks to balance all statutory and other duties placed on the Health Board to deliver health services and improve the health and well-being of our local population and reduce health inequalities. Where it's recommended that we take assurance and delivers the Health Board's agreed strategy, a healthy caring Powys, complies with the NHS Wales planning framework and meets the draft level 4 Welsh Government escalation and intervention framework de-escalation criteria. We note that the annual plan includes the financial plan and options to achieve an end-of-year forecast nearer to the target control total, which involve a number of areas, including provider and commissioner performance. We recognise that further work will continue, both locally and nationally, on options to improve the financial plan position. We recognise that in approving the plan, there are aspects that are subject to further discussion and decision. For example, the 4% increase for the Joint Commissioning Committee, and we've had an oral update on that in our meeting today. We're also asked to approve the annual plan for 25-26 and its associated deficit financial plan, noting the plan's underlying deficit of 38.4 million, with agreed actions identified to reduce this deficit to a potential 16 million for submission to Welsh Government in line with the deadline of the 31st of March. And also to delegate the final sign-off of the plan to the Chief Executive and to me jointly, acknowledging that minor amendments will be made prior to submission. Colleagues, would anyone like to indicate that they don't support the composite recommendation? That therefore is supported unanimously. Thank you very, very much indeed. So we are going to take a break now, given that we are face to face, and it will take a little longer for us all to go into the kitchen and make a cup of coffee and so on. We probably do need the 15 minutes, and so it's now nearly 22, and so 15 minutes from 22 is 5-2. So we will reconvene at 5-2. Thank you.
Croeso nôl i'r cyfarfod ac dyn ni'n symud rwan yn ein hagenda at item 3.2. We turn our attention to item 3.2 on our agenda, and I'm going to invite Pete to present this item on the capital programme. Thank you.
Yeah, thank you, Carl. Please just everyone note that there's been a little bit of discrepancy in some of the year references within this paper. This is the especially capital programme for 25, 26, 26, 27, as is detailed throughout the paper. I just want to highlight a couple of things. I'll take the paper as read. A key point to note is our discretionary capital allocation is going to be increased from 1.431 million to 2.7 million. That is a significant increase for us in Powys, and it's very welcome. That is the area of capital funding that we have full discretion to spend in the areas that we choose to do. It's worth noting that there's ongoing support for the refit programme, where we benefited from additional funding to then spend to improve efficiency in energy and to release revenue savings. The new targeted estates funding, that sum of 40 million that was referenced earlier in our meeting, been available. We've submitted bids to the tune of 3.5 million. We've had confirmation that we've been successful and we received funding of around circa 2.4, 2.5 million. Again, that's very good news in terms of that moving forward. So just then really to reference in the table as described, you have the anticipated funding, our discretionary funding, other contributions, and then various schemes, including work around the Llanford Brinian Health Hub, Llandrindod Phase 2, and the North Powys Integrated Hub, which gives us a planned programme for 25-26 of 8.5 million, and then into 26-27 of 28.8 million. I think they're really the key things I wanted to highlight, and then happy to take any comments, questions as needed.
Thank you, Pete. Please, Ian.
Thanks, Jay. Yeah, thanks for the paper. It's really sends obviously some good news. It's Ian Thomas, sorry, independent member. So it's good news in many respects. I'm curious around where we are with the risks and the project prioritisation. Given where we are with a lot of our asset and our perhaps we're a little bit behind on some of our reactive maintenance, I guess. In terms of the project prioritisation, I'd like to seek some assurance then. Are we using some of this funding for what is effectively reactive maintenance by just replacing things which are broke but could be fixed, but we haven't got the money to fix them?
So that again that's not a yes no answer. There will be elements of things which have maintained given the level of funding that we receive, which we do well in terms of our allocations based on the good work that the capital and estate teams do. We use that to maintain our estate to the best possible condition. Sometimes that will involve keeping things going rather than being it as in a perfect condition, if you like. We do have a significant backlog maintenance challenge, and that's sort of ongoing prioritisation, use of the capital programme, use of funding, use of slippage at the end of the year is all used in a way to maintain our estate and to align with those priorities. We have our innovative environments group, which is a subgroup of the exec committee, which meets, which oversees all of those elements in the capital programme, and there's various other forums in terms of maintaining our estate as needed. So it's all aligned, but it is making the best of what we have, I guess, is the phrase, but within that context as I've described.
Thank you. Can I ask a supplementary question? Thanks, Chair. And in terms of the refit, the decarbonisation programme, is this investment going to significantly move us to where we need to be, or is this an ongoing process that we'll be likely to see over the next 5 to 10 years?
It's more an ongoing process.
Okay. Thank you.
Thanks. Can I just firstly seek assurance that the programme is aligned to the plan that we've just approved? And secondly, I can't see anything, maybe I missed it, around digital. So is there provision in the capital programme for taking forward our digital programme as well? So,
yeah, so the short answer is yes, the capital programme and plan is aligned to our plan, so that is interlinked. In terms of the digital element, there is the Digital Priorities Investment Fund, so there is a separate source of funding around digital. There is normally a nominal element included in our own plan in terms of equipment refresh and those sorts of things, but there is that separate funding stream for more significant digital development.
And are we confident that will deliver for us this year what we need in terms of plan, particularly around WCCIS and those elements?
For this year or for?
Oh, sorry, for 25-26.
It's a shame that Claire Madson's not here in terms of that digital question, but nothing's been escalated as a serious risk or concern at this stage. So I would say that it is in reasonable position.
Hayley, please come in.
Just one additional point. I think that from the point of view of digital investment, nominal figure in our plan, but we have been quite successful previously in additional year-end monies to support some of the digital investments, but clearly some of the national priorities we're taking forward as well. We've got that planned in terms of the digital programme going forward. So I think we're taking the same approach as we've done previously, because we couldn't address some of the bigger digital issues through this particular route, but I think it's one to watch, particularly for some of the key programmes. For example, the WCCS replacement does change in terms of strategic direction nationally around that. So we'll keep an eye on it and keep that flexibility, because I think one of the key issues as well is how we manage in the year unforeseen issues as an organisation with the level of backlog maintenance that we've got as an organisation. We've got to ensure that there's a level of contingency planning there so that we can deal with Ian's point, which is we're quite strong on the planned preventative maintenance with the statutory elements, but the reactive work, we need to make sure that we can respond in extremis when heating systems go down or there are particular issues that we're facing.
Thank you. I'm just looking at the GEF bids for 25-27. And I really don't want to go down into the weeds, but I just want to make an observation. Thermostatic radiator valve Spa Road, 45k. I can go to a warehouse not far from here. I can get a thermostatic radiator valve for £8.55. I can go. Other warehouses are available, of course, but I can go and get a top range radiator valve for about £40 or £50. So when something like that is put forward, I'm assuming that we're talking here about smart thermostatic radiator valves that are linked to a smart building and the maintenance of it, and perhaps to local internet. But it just, and does Spa Road need 100 such valves? I don't know. It might do. Having looked at it yesterday, I guess it's possible. But there's just some aspects of the amounts that are there that to me seem a little bit odd.
Yeah, I can't answer the detail you're asking, Ronnie. What I will say is that the team do their absolute best to maximise all funding that we receive to stretch that as far as possible. So there won't be any element of things being done unnecessarily. Everything done will be looking for the best value, the best price. And I can give that assurance that that sort of work will be part of all of the action within this capital programme.
I think what I was also just reflecting on was how much of this work is actually delivered in-house, a DLO operation, and how much of it is contracted out. And are we sure that we're getting the best value from money in relation to that? That was my second question.
And so any external contractors will all be contracted with under the relevant procurement rules and arrangements. We can arrange for a future paper deep dive, given more analysis and detail behind that, if that's something you'd like us to bring to one of our future committees.
Ronnie?
Personally, I would like to see that, but I would equally like to feel that that request was supported by others, and I'm not asking for something which is atypical, Chair.
Okay, I'm not going to put it to the vote. But if anybody thinks that that wouldn't be a priority, then please do indicate. Otherwise, I will take Ronnie's suggestion and Pete's response as an action. But Helen.
Yeah, thank you, Carl. Just a point of offer, really. DNP committee have obviously got a role in the capital estate, so that might be a route, and we have relevant reports there, so that might be an option, Ronnie, to consider. But not in a formal sense, but as you know, we run a programme of board briefings that are designed to provide board members with information across the organisation. Ironically, there is one on capital estates coming up in the next few weeks, so that might also be an opportunity. So not for a minute, Ron, to say that the assurance report doesn't need to come back, but they might be 2 bits of information that's helpful.
That is really helpful, Helen. So my suggestion, Ronnie, if you were content, is let's take those observations and comments from the meeting today. Let's ask that they be addressed within the board briefing initially. But if you or others feel after that a deep dive within one of our committees would still be helpful, then we can pursue that.
I'm entirely content, as long as we have a way forward.
Yeah, thank you. Ian.
Okay, thanks, Chair. I got a further question. I was seeking assurance really around the capital team and the resource moving forward. As I mentioned earlier, we spent some time yesterday at Llandryn also, so it was really good to see what was going on there in terms of the fit. And some time at the Spa Road there. There's obviously quite a lot of work currently in progress due to that acquisition. My understanding is that with 50 schemes for 24-25, they have been of varying sizes, obviously from quite small to what are relatively large ones. And we're delivering them very much with a reduced team, a team of 5. As the challenges are going to grow, I think in future years, are we going to have the capacity to be able to deliver as we are currently 3 vacancies down in the team?
So you could apply that question to all areas of the health board. So my response would be that we continually assess our capacity against our requirements to deliver. There will be vacancies at times and we work hard to fill those. The programme is put together and the capacity needed to deliver that programme is always considered and then linked to our current capacity, and then any other additional resource required is then considered. With the capital programmes, the more significant ones, you do get elements of programme funding as well, which can help in terms of that capacity. So it's a great point to raise. It's an ongoing consideration in this area, in all areas, and it's something that's always under review. I think it's the short answer.
So I'm going to give last contribution to Hayley, then we will complete this agenda item.
Yeah, thank you. Really helpful questions for both Ronnie and Ian. And I think the balance here is around the strategic question for us as a board is how do we secure a reliable source of strategic capital to support a substantive capital team. So we will naturally get bigger or smaller depending on the level of capital investment we're managing and the number of projects we're delivering. So I think I'm raising it because there's something about also a DLO, a direct labour, that we've got within the team. There's an efficiency that we have to deliver, and where we've got peaks of work, which happens sometimes because we're attracting funding, we actually supplement that workforce to deliver as a result of that. But clearly the broader context of available capital across NHS Wales is very constrained. So we've just got to balance that, but just some reassurance, I think, here that we are able to flex up when we have additional resources. But at the moment, we haven't secured that substantial increase in our strategic capital pipeline to enable that to be a part of our substantive team.
Thank you.
Thank you very much, Hayley. So we will move to the recommendation. We just note that there is an error on the paper. So just for clarity, that this is for 25-27, not 24-26. But with that minor important correction, the recommendation is that we approve the discretionary capital programme for 25 and 27. Again, please indicate if you don't support the recommendation. So that's supported unanimously. Thank you. We turn our attention to item 3.3 and the report of our Director of Corporate Governance, and therefore over to you, Helen.
Thank you very much, Carl. So pleased to provide the report for you today. It's in a format that I hope you're now familiar with and receive at each meeting. The first part gives you an overview of board activity, as you're all aware. A brief update then on the Healthcare Professionals Forum. So this is an advisory group to the board that the Health Board hasn't had in place for some quite considerable time. Following our own review, but also feedback from our external auditors, we're now working at pace to make sure that we get that back in place. And you can expect as a board to see some further information in the terms of reference for that in your May meeting. That won't stop our progress. We'll be continuing to get that up and running in the meantime. In terms of the application of the common seal, we've applied that on one occasion, and I hope you can take assurance that that's been done in line with our standing orders and processes. In relation to standing orders then, there are some recommended changes in here for board approval, most of which we've received recommended changes from Welsh Government directly to our model standing orders. They've been considered by our Audit and Risk Assurance Committee earlier on in the night as well. Probably the most noticeable one is that there is a clarity now of the recognition of electronic systems. Board papers will now be released 5 clear days prior to a board meeting, as opposed to the previous 7. So in reality, for a Wednesday meeting, they will be released no later than the Friday morning. There is, as always, the occasional exceptions to that, but on the whole, we are compliant with that new standard. There's a scheme of delegation request. This is in relation to our charitable funds committee. The current scheme of delegation states £5,000 delegation outside of full committee approval. In discussion with the charitable funds committee, we would like to recommend that increases to 10. And Steve, as the chair of our, I owe you an apology because we didn't include that in the review, which was an error on my part, but that's a recommendation to the board. We expect there to be some further minor changes to the scheme of delegation, standing financial instructions, more administrative, but they will follow in. Thank you, Carl.
Thank you, Helen. Are there any comments or questions? No, I'll just say that really pleased to see, Helen, the progress on the healthcare professionals forum. We look forward to seeing that additional information in May, and I think certainly that will strengthen the clinical voice in terms of our business as well, which is something that we have highlighted the importance of in the past. So really pleased to see that. So if not, then we are asked to receive the report to ratify the application of the common seal applied on one occasion since the 29th of January, and to be assured that the action was taken in accordance with section 9 of the standing orders. We're also asked to approve the changes to the Health Board's standing orders set out in the paper, and to approve the change to the scheme of delegation for the financial delegation in relation to the charitable funds applications, as Helen's explained. Does anyone not support the recommendation? That too is supported unanimously. Thank you. We turn to item 3.4, and again to Helen, just to introduce the standards of behaviour policy. Over to you, Helen.
Thank you very much. So I largely take the paper and recommended policy as read. Just a couple of points of introduction. So standards of behaviour policy is a board retained policy as per our scheme of delegation, which is the reason it's here today. It's been reviewed in some detail and recommended to you as a board by both our executive committee and importantly our audit and risk assurance committee. My thanks to the team for some quite significant work on this, and Beth particularly, and some consultation has also taken place across the organisation in its review. Principally, This is designed to strengthen our declarations of interest approach, both in terms of mandating more colleagues to complete a declaration of interest, particularly at deputy and assistant director level for our consultants, and a reinforcement of any colleagues involved in any decisions, particularly in relation to procurement. Of course, declarations of interest is open to any employee to complete as well as board members, but we will be expanding the particular focus that we have. We'll be moving into an electronic system using ESR approach. We've learned from the experience of some other health boards that have already done this and benefited from that. So happy to recommend the policy to you. Thank you.
Thank you, Helen. Of course, this was when we received the committee reports earlier. This was considered by the executive committee, also by the audit risk committee. So you may want to comment, Steve. Thank you.
Well, the comments I'm going to make, I'm afraid, Helen, is I don't think it was considered in the March audit and risk and assurance committee. So I'm not saying that I won't endorse it, but I think if you look at our report, we didn't cover that as any other.
Apologies, Steve. I'll have to double check that then. That may
I just want to make that clarification. I'm not saying that we should endorse it.
No, I understand. And apologies, I'd have to go and double check.
Yeah, of course.
Carl, as opposed to Guess, but apologies for that.
Apologies from me if I've got that wrong.
No, it's not. You're right. It's important to make sure we're right.
Yes, we will clarify that. Thank you, Steve, for pointing it out. Kirsty.
Thank you. I don't want to delay colleagues, but I just want to welcome the paper. I was interested in how we will monitor implementation and monitor performance against that policy. Not that I have any concerns at all, I'm very struck, in the covering paper, it talks about the Nolan principles, isn't it? The principle of openness. And today's been a really good example, I think, of that, of the board living these values. We've had some really difficult things to discuss this morning, but we've done it in a very open and transparent way and with integrity. And I think that, just demonstrates that we are living this policy, but I'd be interested to know how we plan on monitoring implementation and compliance.
Who wants to respond?
Very happy to. Thank you, Kirsty, and support your comments. In terms of compliance, we take regular reports to our audit and risk committee, and I know we do that. We take regular reports via our executive committee and into audit and risk committee. In terms of declaration of interest, particularly, we obviously have our staffing lists and we monitor against those in terms of completion rates, particularly. We also look across other health boards and just check our, in effect, our benchmarking and quality standards. So they're the principal routes of assurance.
Thank you. Mick.
And some really important guidance for staff at every level, including the board within this document. It's all wrapped up in a 47-page document. So I just wonder how that's going to be brought to life for staff, just to make sure that the bits that they really need to understand get to.
Yeah, thanks, Mick. So we've introduced a regular briefing into Hayley's chief executive briefing out to the organisation, which is not in person, but an electronic in-person delivered event, if you like. So we include policy updates there. I think some of the appendices that are included in terms of the flow chart and the how-to guides will help with that. We'll also be rolling out a programme of training across our directorates and at designated sites around the health board. So that will be ongoing, but they're the principal mechanisms.
So we will clarify the ARAC stuff and correct whatever needs to be corrected. But notwithstanding that, the recommendation is that we approve the proposed amendments to the standards of behaviour policy, and if approved, picking upon points that have been made, implementation across the organisation. Would anyone like to not support the recommendation? That therefore too is supported, which means that we're still with Helen and the risk management framework, which I'm hoping was considered at the Audit and Risk Committee, and so Steve, you may want to come in at some point with a perspective from that committee. But first to you.
Thank you, Carl. And I can say with confidence that we included this in exactly an audit and risk. And I know Steve's nodding, and I'm sure he will comment. So again, the risk management framework is a very important document. It's essentially the approach that's set out by the board in terms of our risk management across the organisation, and therefore is a board reserved policy and framework within our scheme of delegation. Again, with thanks to not only my team, but a big team across the organisation, our deputy and assistant directors particularly are very actively involved in this work through our risk and assurance group. The policy we currently have in place has been in there since November 22. So this is very timely that we make sure that we maintain currency, as it were, and relevance with this. And essentially, the key change in here, there are a number of bits we've tidied up, and refocused a little bit, but the principal change, and Ronnie, you made some reference to this in an earlier agenda item in the right way. We are proposing to move to what we would call a strategic risk register, which would be the board-owned risk register, an integral part of our board assurance framework. We would then be introducing an organisational risk register, which would be owned by the executive team and supporting colleagues. The board would have full access and sight to that. I think that's really important, in not only in terms of transparency, but understanding what's where, full sight, escalation and de-escalation. But I think what that will help us do is at board level really focus on what really are those big strategic risks that run the challenge of knocking over our strategy, as it were, strategic delivery. At the minute, we do that, but there is a gap in what we might call our corporate risk register and some of those aspects that are cross-organisational. We need to have clear strategic sights of. So it's in a bid to improve and increase awareness, if you like, and visibility of risks across that spectrum. There will be a programme of training that will continue to support this, as always, and our executive committee will play a key role in making recommendations for changes to the board in the same way that they do now. Another important part of our risk work, and working closely with Claire and her team, we are continuing to move as many of our more local risk registers at department and service level onto our Datix, which is an electronic system that improves reporting, visibility, and the ability to be able to interrogate and analyse risks in a better way. So that continues to be the case, but important that we just note.
Thank you.
Thank you.
Steve, would you like to?
Yeah. Well, firstly, I will confirm that we did. And endorse. I think the one comment that came through in the audit committee was just keeping an eye on the split between the operational risk register and the strategic, and looking for grey areas that, or there may be overlaps. So we particularly don't want key risks, as I refer to them, to fall between the two. So that's just something that we'll keep an eye on over time. So
yeah. Thank you, Steve. And that's certainly, I'm assured by that, because one of my questions when I read this was, what does board ownership of that look like? The perennial intractable for any board is how do we know what we don't know, and sightedness therefore on those on the risks within the operational register as well as the strategic register. I think.
Thank you. Does the sort of framework assist with the escalation between those tiers of risk registers? Does the system support that as well?
So the framework does, and training particularly supports that, and we've increased a bit more clarity, I suppose, into that. So it is a bit about risk numbering, but I don't think it's as simple as that. It's a set of principles that determine how things go up and down as well, and we've incorporated that.
Okay, thank you.
Yeah, just on that point, Simon, I think one of the issues is that I think previously in clear only welcome the developments and also the toolkit development to support its implementation. But I think there's a softer end to this, which is about moderation. When you look at risks across the organisation as they come through the process, whether that's from operational to strategic, that judgment and moderation, both through the risk management group and as it comes through to exec and committees and to board, is really important. And so it's the quality of the conversation around the moderation of some of these risks, which is talking to both Steve's point and Jamie. So I think how we build that in will develop and mature, and particularly recognising we've made good progress in insurance framework last year, but it also needs to have further in-line, further revised framework. Thanks.
I think some of the questions, so, you know, just in my experience, the risk management framework should work well at this level because they get the right kind of focus to the board, to the exec, but it tends to, you know, the rigour tends to deteriorate as you go further into the management layers. I just wondered what mechanisms are going to be put in place to make sure that that kind of dynamic, you know, whole system approach is actually happening. You know, we're going to dip sample, and, you know, what mechanism to get the assurance that the whole system's working, not just the bit that we see.
Yeah, thanks, Ben. It's a really helpful question. So we've got a risk and assurance group that our Deputy Board Secretary chairs. It's a subgroup of the exec committee, and that's attended by all of our assistants and deputy directors. So that's a really important mechanism. But of course, it's deeper than that. Training is an important aspect. We do an internal audit every year on risk management, and that looks at our corporate systems, but then dip tests at least 2 service areas every year. We change those every year as well. So all of that will continue.
Thank you.
So, picking up on that, Helen, how would we as a board, perhaps through our receive the assurance that the effectiveness that, or the risk to effectiveness that Mick is highlighting is either eradicated or mitigated?
Yeah, exactly. It's exactly through audit and risk assurance committee. So at least once a year, more likely twice, we would do a specific session on risk assurance in terms of the risk management framework, and we would explore that in some detail.
Thank you. I don't see anyone else wanting to contribute, so we are asked to approve the revised risk management framework. Yet again, please indicate if you don't. That too is approved unanimously. We have at item 3.6 the draft minutes of our previous meeting of the 29th of January. Initially, for accuracy, does anyone want to suggest any changes that you think may need to be made? No, so they are approved as a correct record, which then takes us to item 4.1 and to our financial performance report, and to Pete.
Thank you, Carl. So the finance report is in the usual format. Given the conversation earlier around the financial element of the plan for next year, I'll just go over the key sort of points, and then we can pick up on any questions. So as I mentioned earlier, we're on track as of month 11 to hit our £15.8 million deficit plan figure. As of month 11, we have an overspend of 14.45 million, which is in line with our deficit plan of 15.8. It's worth noting the total capital spend as of month 11 was 7.8 million against the capital resource limit of 14.3 million. As previously explained, we were successful in achieving additional funding towards the latter part of this year. Hence, our profile spend has been weighted more towards the end of the year. The latest indication I've had is that we're going to hit our capital resource limit with a very modest small surplus against that figure. So that's all on track to deliver. Included in the report is the usual analysis by key expenditure area, with the deep dive slides then into our provided services, our locum and agency spend, our commissioning, contracting, our detox, and there's an additional slide now included in relation to our mental health private providers. This is an area where we've seen an increase in our spend year on year. It's an area that's been highlighted and one that Elaine and team are focusing on just to make sure that we're doing all we can to minimise that expenditure. This arises basically when we do not have the capacity to care for people needing care, or whether people are needing a level of care that's beyond our skill level, so are cared for in other bodies. Same analysis in relation to prescribing and continuing healthcare. Again, I'm not diving into these areas. We've discussed them previously. The board understands our key pressures and areas going forward and what's needed for next year. Just to highlight on the savings page, though, against our savings target of 9.9 million. We are on track to deliver 10.5 million, so exceeding that target. That is good news, and it's a well done to everyone, all the budget holders within the organisation for helping to contribute to deliver that. Noting that the exceeding the target was on the back of those additional actions we needed to take at the end of the year to hit our plan figure. Also worth noting that of that 10.5 million, 6.7 is recurrent. Clearly, the level of recurrent not being at the total level becomes an ask into the next year, and that's part of our underlying deficit that we discussed earlier. I think they're the key things I just wanted to highlight. As always, happy to take any questions or comments.
Thank you, Pete. Steve.
Yes, thanks, Pete. Firstly, I just wondered if there's any reasons for the increased agency usage in February. I've got a few questions, so I'll run them all through. I know that it appears that we still haven't agreed contracts with English providers in month 11, which seems a bit delayed, but maybe just have clarity around that. The capital delivery this year is outstanding. It's been a concern of mine during the year that we wouldn't deliver so to hear that has been delivered is fantastic. I would just say that in the audit committee we did receive from Audit Wales their audit plan for this year, and they will be obviously having a focus on capital spend in terms of the year end. So I'm sure there were really concerns around that. And finally, yes, savings achievement is very good. But I suppose the two questions really around the agency usage and our current position on in terms of contracts for this 24-25 year.
It may be better for Elaine on the agency use and Nicola on the contracts that come in, if that's okay, Jim.
Okay.
Yeah, it's a noticeable shift upwards, isn't it, in month 11 for agency usage. A significant amount of that relates to both sickness of staff and also some of the acuity that we've seen in the system. We have implemented an escalation framework for all agency requests now. So on the back of the month 11 position, we're doing a rapid review of that to understand the impact and any learning that we can, because that step up wasn't something that had previously been escalated to me, other than through that acuity that we're seeing. So we're going to take a deep dive and we'll be able to look at what else we need to do around that.
Thanks, Jen. I think that stock statement is probably a little bit not quite where we were in month 11. So we had agreement in principle with our main English providers by month 11. There were some challenges, particularly around Wye Valley, which we've had to bottom out, which we bottomed out with some success for us as a commissioner. And the board are fully aware of the issues around data with Shrewsbury and Telford hospitals, which again, we bottomed out with them and come to an arrangement about that for this year. And it is fair to say that formal agreement and sign off that late in the year is not where we'd like to be next year. As we enhance our grip of control, I have written out to all the providers they would like to come to agreement in Q1, and then we're working with the ICBs to collaborate with them on performance management as well. So but just to give that assurance that we certainly had agreement in principle by month 11, we're just dotting the I's across the T's and getting the actual documentation signed.
Thanks. I'll put you just on that point of the Shrewsbury data.
Yeah.
So it's good to hear. So are you saying that issue will be resolved by next financial year?
So the feedback we've had from them is that they won't